This conference will now be recorded.
Welcome, dear guests and dear friends, to the first session of Complex PCI workshop in Online Cardiology Club. I am Sercan Okutucu, interventional cardiologist from Ankara, Turkey. Firstly, I am very happy and honored to attend this program, which consists different topics in coronary interventions. We have an interesting first session today, namely contemporary technique of CTO. And as we all know, outcomes of CTO have improved because of advancement in equipment and techniques, and it's very crucial to learn enough about the main principles of CTO interventions. And today we are very fortunate to listen this topic from a big expert, Professor Sunao Nakamura. We would like to cordially thank the professor for giving time to us. And I personally expect to learn and grasp much information from these sets of webinars. And importantly, thanks to our dear friend Nerian Özgül for sharing this privilege with us and making this program possible. Dr. Özgül is a young and active interventional cardiologist in our society. She will moderate today's session, and I will not steal more time from this event. And Dr. Özgül, stage is yours, and now I will send the screen sharing request to Professor.
Okay, thank you, Dr. Sercan Okutucu. Hi, everyone. I'm very happy to see all of you here. First, I want to introduce myself. I'm Nerian Özgül at Gümüşhane. I'm an interventional cardiologist just for 2 years. Today, I want to thank Dr. Sunao Nakamura for accepting our request for this online program. I want to give some information about him. He is the president and the director of the New Tokyo Hospital, which is a cardiovascular center at Tokyo. He is also a visiting professor of the Kumamoto University and consulting the National Center Cardiovascular Center at Osaka. Behind, he is a good, dedicated interventional cardiologist. Also, he is a good mentor and teacher. The most important thing I have learned from him, if I know what I face to face, I can know what I'll do. This is the main sentence of me while I'm staying at Japan at New Tokyo Hospital. Today, Dr. Sunao Nakamura give a lecture about the current techniques of the CTO legends. If you have questions, you can write your comments and questions on the chat box. And for the good online connection and for the good presentation, please keep your microphone silent places. If everybody is okay, if everything okay, we can start. Dr. Sunao Nakamura, shall we?
Yes.
네.
最初から
こっち
閉じちゃっていいの
いいよ、これで。Hi, everyone. Can you hear me?
We can hear very well, Professor.
Okay, so let's start.
Yes, we can hear you, Sensei.
じゃあ、俺の顔消しようかな。
先生の顔これ
消せる
でもこれ消しちゃっていいんですかはい、どうぞ。
Okay, so good afternoon, all Turkish fan ladies and gentlemen. First of all, I'd like to say very congratulations staff at the Web CTO meeting. I'm very happy to join you and a pleasure to share my idea. これついてない ?OK。こいつロックされてる。just wait. じゃあそれで。First of all, I'd like to say, now we face a new era of the CTO intervention. We have various kinds of techniques, especially the retrograde approach. Now we have a new devices. We have a good enough weapon for fight and about the knowledge opening up so-called algorithm and the knowledge regarding the selection of the case, randomized control trial which proves the real indication of the CTO and so on. Today, I just want to emphasize the important message for you. paradigm shift. Look at this guy. This is a pioneer in Japan. They conquered our land more than 25 years. No doubt they are a good city operator. So because many were great senior, actually younger guy doesn't grow very much in this 10 years. Okay. But listen to great advancements of these 3T, techniques, technology, rule of thumb. Now we face a new era of the CTO intervention. Just want to say CTO PCI is not for the CTO dedicated operator, but for the every intervention carriers, younger intervention carriers. Actually, this is you. Again, even the young intervention carriers, you have a right to start a CTO PCI. This is very important, remember it. So let's start my talk about how to tackle with a difficult CTO. This is the schema of the CTO. As you can see, we have a clear stamp both sides, proximal distal, and you can see some streamlines like archipelago. Everyone think this is easy one. Even without the archipelago, you can see some streamline like a putting line in a golf. Everyone think also this is easy. But you lost some stamp of the CTO entry. Suddenly you lost the clue of the entry point. So your fingertip wander around the area of the starting point. And if the CTO length is not so far, you can see some streamline. So this is not so easy, but not so difficult. But once, if the CTO start the area of the bifurcation like this, and you don't have a stamp, and one more, if the CTO length is a bit far and have some bending like this case, suddenly ranking of the difficulty climb up to the top. Okay, these are the factors which raise the difficulty of the CTO. Among them, no stamp is one of the most challenging parts. So today, just focus on this topic, no stamp. Actually, these are the 7 important factors you need to recognize. First, anatomy, and then find clues. IVAS guide, coronary CT guide, retrograde guidewire assisted technique, well-on tactile feeling, and combination shot. This is the case of no stamp versus CTO, but you can see very carefully, you can recognize the inflection point, which shows the course of the occluded RCA like this. Once the guidewire went into correctly, you need to confirm the guidewire position with several different views. In this case, RO and LO. Then, if you're good enough, you open up the front door of the CTO automatically went into the goal. 10 minutes, 15 minutes. Second, find clues. Mostly need a combine shot. This is the case of a north-south circumference CTO. Now you can see the classification. So you can see the root of the vessel actually from the beginning. Actually, this is the 2006, 14 years ago. This is before Gaia, before retrograde approach. At first, of course, antegrade approach. This is big trend of the retrograde approach, actually. So we need to do the antegrade approach. And this is not Gaia. And we could negotiate the curve, calcified area. This is a little bit difficult. And then after several times, guidewire gradually approach the distal target, gradually approach. Of course, sometimes need to change the guidewire to the harder one. This is maybe a conquest. This is very difficult to control, but we need to check the several different views to confirm your guidewire position. Okay, checking the approved view to confirm the guide wire position, and then now approach to the distal target very correctly. And finally, guide wire reach the goal island. And then dilatation, pre-dilatation, many times with several different view. Of course, proximal part in a false lumen, but there's no branch, very important branch, so we can do the ballooning and the stenting. And then this is the final angiogram. So now we recognize parallel guide technique is a still core, very important technique. You need to recognize, very important. Third one is the IVAS guide. So look at this case. This is left main severe stenosis of circumference and non-stump LD CTO. So actually, how do you think this is difficult or not? So actually, this is not so difficult. Actually, this is a case of most appropriate IVAS case. So because if you have a big space of the left main, you cannot see the entry point. But if we have a narrowing of the left main, definitely you can see the entry point. Trust me, definitely you can see. Now, if you can open up the entry, wire going to very correctly. So again, if you don't have a big space or left main like this, you definitely can see the entry point of LED CTO. If you have a big space or left main, of course, I said before, you never see the entry point. If you can open up the front door, automatically your guide wire going to the distal and then check the several view to confirm your guide wire position. Just this is a technique of the tracing technique, like solving a maze. We can say wall floor. And finally, no difficult to complete the procedure actually within 30 minutes, because if you just see the entry point and if you trace the wall floor and then the balloon and the stenting. Number 4, coronary CT guided. This is a little bit interesting. This is a case of a non-stump LG CTO. Actually, no stump. As I said before, this is a big space for left main. This kind of a case, even like this side branch, you never see the entry point. And this is a case of a no retrograde option, so no way anterior approach. In this kind of, anyway, check the IVAS, but you never see the entry point. Actually, in our center, we have a very crazy coronary CT guy, very crazy guy. And he presented me a very nice picture of the coronary made by the coronary CT and gave me exactly the same position I want. So we can say the coronary CT guided. We can use many of the projection and we can confirm the wire position very correctly. Now guide wire went into the place which is very reasonable. You can understand the epicranial and the spider view. And finally catch the distal. And need to confirm the several points. Maybe I think mid of the LED we need to use epicranial, and then this is the true lateral. And then this is the final. No doubt, actually, if you use retrograde, leave it taking time, but if you use anterior approach and if you catch the true lumen, maybe I think we can finish a very short time. Number 5, retrograde guide wire. This is very important, actually. This is a very important factor. Can shorten the length of the you and me. actually a very expensive doctor like me, and so far 10,000 CTO in my whole life. So actually, maybe compared with you, it looks like a bit different, but actually, if you can use a retrograde approach very correctly, so this, the length is very short, very important. And if you if you are the good operator of the retrograde approach, 60% non-stamp case can be opened up. Look at this case. This is LED CTO with left main. Do you understand where the entry point? This looks quite difficult. And then this is RCA. Okay, you can see the not so beautiful collateral and some smoke sign. This means an old CTO. This is also the not good information for the operator. This is old CTO. Okay, and of course left main. And you can see the distal part of the collateral. We can see some promising channel, but which is not easy to track. Watch carefully. Very small tortuous, very tiny collateral running into the LED. Not so easy to track, but can track. This is actually SO03. Because the guidewire technique successfully trace the collateral and then go into the LED. Okay, and also guidewire and Corsair tube catheter also went into the LED mid part. Now, because the retrograde guide are approaching the LED proximal, so you can see the root of the CTO. So we can do the antegrade guidewire into the LED CTO a little bit easier. Then approaching both antegrade guide wiring, retrograde wiring, and then want to do the kissing. And then antegrade wire just kiss and then went into the LED. And then Baronier stenting. This is the final result. So just want to say, if you have anyway good collateral, everything is okay, even a no stamp. This is very interesting case. No another LED no stamp CTO. Okay. Actually, we have some looks like some small stamp. So first try to do the IBUS guide, but because you can see some qualification proximal part of the LED, because of the disqualification, IBUS never see the entry point. But after several try to integrate approach with parallel wire technique, okay, wire is coming closer but a little bit far. And I feel the very difficulty to go into the distal collateral, then change to the retrograde approach. But in this particular case, looks like not so bad collateral, but like a small, tiny collateral wire can go through, but Corsair cannot go in and never creeping up. The only wire going to. So we want to do the kissing guide wire technique. After several try, untethered guide wire successfully went into the place of a retrograde wire. Looks like this. Right panel. And then check angiogram. Now, how do you think? Looks like this. This part, definitely okay. But the middle part, little bit doubt. So in that kind of case, check IBUS. So now, IBUS can tell us that this part okay, but the middle part of the CTO side, wire went into the subintimal space. If we continue the procedure and the Baronier stenting, we lost some very important septal branch. So we need to correct the position. So-called IBUS guided rewiring. We just place the guide IBUS, just the position or the wire went into the subintimal space and then just place it. And then want to see this picture. Left panel, the play, wire was in a subintimal phase. Right panel is a guide wire, just in a true lumen. Then balloon stenting. And then beautifully open up with some septal branch. This is we did a combined shot like antegrade and then retrograde and then IBUS guided. So the last one is tactile feeling. This is very a bit special. Now I already told you the importance of coronary anatomy. This is just a schema. No stamp LED CTO. Left panel spider view, right panel AP cardiac view. Okay. Even if you don't have a stamp, actually root of the LED is almost fixed from the beginning. Please remember it. Spider view, AP cardiac view, root of LED should be like this. AP cranial view, LO cranial view. Interestingly, we have some bending at the part of the diagonal branch. On the true lateral view, you need to remind this anatomy. This is a case of definitely no stamp LED CTO. Okay, under this case, it's a no retrograde option. So we need to do the antegrade. Okay. At first, please look at the angle of the guide wiring. Angle of the guide wiring. This direction is exactly the same direction of the right panel. And then check the spider view, and then look at the chip of the guide wire. Guide wire direction is going to like a right panel. Just want to say, I think even no stamp, it's actually looks like a no stamp, but I think a 50% case we have some stamp. You need to feel it. Even if the invisible by the eye, 50% case still exists. And then if you catch correctly, wire went into the actually right position. Of course, check the many several view, and then this case, fortunately, we have some clarification, so we can see some hint. Of course, check several view. This is true lateral, and then this is the final angiogram. Again, I said, if you do the retrograde approach, maybe to take in time, maybe 30 minutes, sometime 1 hour, 2 hours. But if you do antegrade approach, mostly we can finish the case very shortly. Actually, it's a little bit not so easy to get this kind of tactile feeling. But believe me, we have done many CTO with this technique. So finally, I just say stay focused. Maximize your clear sentences to breaking point. Thank you very much for your attention.
Thank you very much, Dr. Sunao Nakamura, for your good presentation. If you let me, I want to ask the first question.
Okay,
How
please.
often do you... Okay.
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 How often do you use IVUS-guided PCI at your sentence?
Okay.
Percentage of
First of all, I need to explain the Japanese situation about reimbursement system. Okay. So Japan, very bit crazy country. IVUS, OCT, FFR, any physiology guide, all reimburse. So from this meaning, IVUS guide, more than 95% we do IVUS guide PCI. Okay. About the CTO, maybe I guess in case of some difficulty, okay, in case of some difficulty, we do IVUS guided, CTO wiring to establish the CTO. But every case, after stenting, of course, checking IVUS. But in this kind of IVUS guided wiring, it's maybe, I think, around 20% of case.
20%. But I want to ask one more question. When do you prefer using it? At the beginning of the procedure or after trying to crossing the lesion with anterograde and retrograde techniques, when you don't achieve the past this, after that, do you prefer to use that?
I'm sorry, one more time, please. One more.
Okay.
It's very difficult
When
to
do
catch.
you prefer using IVUS guided revival? Could you hear me? Excuse me.
Okay, 50% can catch.
Your voice is some part is disconnected.
Okay.
Maybe you can write the message.
Okay. I'm asking again.
Okay. Okay.
Oh,
About,
okay. Okay. I can write it. Okay. I'm writing.
Okay. So そしたらなんか時間かかんじゃん、そういうこと。退席しました。書いた When do you prefer using iBasket PCI after anti-retrograde technique if you don't achieve the pass? So, okay, in the case of IBAS guide, okay, in the case of IBAS guide, you need to know the timing to use the IBAS. You need to select the appropriate case of IBAS use. So today I just show you the very appropriate case of IBAS use. Like even a no stamp, if you have a narrowing, okay, if you have a big space, IBAS never we cannot see. But if you have a narrowing, you can see the entry point. So anyway, maybe around 5 or 6 appropriate case, we can use IBAS very usefully. Okay.
Thank you. Thank you. Dr. Nakamura, there is one question from Behrat. I think he want to ask that which one do you prefer? Parallel wire, stingray, dual lumen microcatheter, IVUS guided?
Okay. Anyway, thank you very much. This is very nice question. Very important question. First of all, we have some history of the stingray and like a dual lumen catheter. mostly like but anyway, stingray. Of course, we can use a stingray in some case, but mostly if you are good enough for the parallel wire technique, if you can use a good enough technique for the parallel wire, then we can finish the case. The one big weak point of the stingray is if you use a stingray, the stingray wire, a stingray catheter mostly go into the subintimal space, maybe I think 2 centimeter, 3 centimeter. And if you continue the procedure, sometimes lose the branch. Okay, so if you use a stingray, even if you catch the distal, okay, even if you catch a distal, you need to correct the position of the subintimal space. Do you understand what I said? Okay, stingray is okay. But if you use a stingray, finally you need to correct the wire position, subintimal to lumen by IVAS. This is stingray. And dual lumen catheter. Weak point of the dual lumen catheter technique is dual lumen catheter place some position. So actually, even if you use a dual lumen catheter, 2 wire, it's a little bit difficult to control. If your wire is a subintimal phase, second wire, it's a little difficult to catch it. But if you use the 2 guide wire independently, much easier to catch this. Do you understand what I said?
Yeah, we understand, Dr. Nakamura. And one more question from Alper Karakuş. What are the basic materials in the angio lab, cath lab for starting the CTO procedure? What do you say about that?
Basic material.
Yes, for the beginners.
So you mean a guiding catheter or a guide wire or something like this?
Yes, something like that.
Okay. So at first, every PCI, you don't need a backup. Okay. If you face some difficulty to bring the stent or something like that situation, you can change the guiding catheter curve. Okay. But in the case of a CTO, you need to use a backup catheter all the time because of the if you do the guide wiring, you need to feel the back, you need to feel some feeding backup from the guide wire. So you need to use always you need to use a backup guiding catheter. Feeding backup, you need to feel. So in the case of RCA, like anyway, backup catheter and the EBU or something like that backup catheter. First of all, you need to use a backup catheter in the case of CTO. And second, you need to use some tube catheter, even a fine cross or Colcian or any tube catheter. And then first, you need to use your favorite guide wire. And then finally, you need to use like a Gaia or something like a CTO guide wire. Do you understand what I said? Anyway, guiding caster should be backup caster.
Excuse me,
Yeah.
Dr. Nakamura, I couldn't hear your last words. Could you repeat that again, please?
Okay. About the PCI system. First of all, you need to use a backup
because of the
cluster.
connection.
Okay. Better to write? ここじゃあ、better to use a backup catheter all the time. Use backup catheter. キャセター。
こうですか？
うん。
カセター。
うん。
オール
all the time.
これで
うん。まず。で、better to use a tube catheter like a corsel. Catheter all the time.
ライク。
ね、だからいいよ。
いいですか？
うん。
これで。
うん。で、次。And, next guide wire is just you need to use your favorite guide wire. For me, Gaia. うんうん。Gaia.
これで。
うんうん。You understand?
Yes, we can understand. The Nerian has a little connection problem, and
Okay.
I will be happy to ask the questions that come from the audience.
Okay.
Dr. Humayun Kakar asked about the which guide wires are your workers guide wires that you commonly use.
CTO. Okay. I'm biggest user of the Asahi Intech guide wire. So anyway, Gaia. Gaia first, Gaia second, Gaia third for Antegrade. And then for the retrograde, actually first we need to catch some small branch. So from this meaning, first need to use like XTR or this kind of guide wire, and then all the time using a SO03, which is very sophisticated guide wire for CTO channel tracking. Even the epicardial channel septal branch, we use SO03. This is my workforce guide wire.
Thanks a lot. And we saw a very nice image in coronary CT guided technique. Which is the place of this technique in your clinical practice? Do you use commonly?
No, actually, I have a more than 20 years CTO PCI experience. And actually, CTO PCI itself is like my fun. So if we have a big information like a coronary CT, this is too much big information for me. So usually we don't use, I don't use coronary CT, but if you use a coronary CT, all of you, if you use a coronary CT, very big information, root, angle, location, the qualification, definitely you can understand. This is big guide. Today's my lecture, the slide. This is only for the lecture, so I present it. But usually I don't use.
There is one little philosophical question: skill, experience, patience, and feeling. What is the most important in CTO PCI?
Oh. I think I'm a very old doctor, so should be good doctor. And I really need to say, we need to recognize we are doctors. So we should do the right thing for the patient. So always talk with all patient and patient family, and then should answer the patient family question. And then if the patient requests me, we need to effort 100%. Just it.
And Dr. Hassan are asking a question. He commented, I think the operator should be ready for the CTO complications also. The operator
yes.
should have graft stand, coils, etc.
Yeah. Actually,
And,
I said I have a 20 years experience, so much complication, maybe I think very younger day. And so much graft center, so much perforation, so much pericardial synthesis. Actually, I have a good technical pericardial synthesis. This is not not good, but in my younger days, I have a lot of experience. So now I know the way to avoid the complication. Okay, so this is also the very important thing to share. How to avoid the complication. From this meaning, so actually understanding the anatomy is also very important. And the coronary CT, before studying the coronary CT, is also very important.
Thank you very much. There is another question asking that, is there any new wire in CTO armamentarium in Japan?
Okay, we have a Gaia-Nex, and because of the actually COVID-19, so all of the manufacture also stop. And maybe I think a company want to make a new one, but every the step is very stop. But I think Gaia-Nex. Actually, if you have a next chance, another chance, maybe I think I can show you the importance and also the difference of the Gaia and Gaia-Nex. I think if you have a Gaia-Nex and then SO03, I think 99.9% it should be okay.
Thanks, Professor. And Behrad asking a question. Behrad, can you make your microphone on and ask? He is from United Arab Emirates.
Hi, dear Professor.
Hi.
I just asked a question. Usually, sometimes when I do a CTO procedure, I make a very large dissection plane, especially in the antegrade approach. And after that, when I see the distal part is it's a very bad vessel after the dissection plane, I just do a stenting in the proximal part, and sometimes I leave the distal part with just to the drug. Sorry, disconnected.
Okay.
Yeah.
Okay,
I just want to know, that if we have a large dissection at the distal part of the re-entry, can we leave it with the drug-coated balloon or just leave it and just stent the proximal segment and see what's happened in the future?
Okay. Depend on the situation or depend on maybe your situation. So actually, if this is in Japan, if we have a big dissection, the CTO part, maybe I think we just leave it and then maybe around 3 months later, we try again. Maybe I think this is much better. But if you place a stent in a subintimal space, maybe I think if you do stent, maybe so actually later maybe it's very difficult to open up open up the CTO. So maybe better to leave it.
Thank you.
Okay, Sensei, one more question from Humayun Kokar. Which CTO lesions we should not try to revascularize?
Very good question. Very good question. Currently, as you already know, we have 20 intervention guys in my center. They do some investigation, each doctors. So one guy doing like this, And then now we recognize actually ischemic area less than 10%. It's maybe should not touch. Ischemic area less than 10%. But currently, we have a very interesting paper which show that even some, scintigram test show that even 5% something. But if you open up and then, area of the CTO territory is getting bigger. Of course, still we need to do some study, but anyway, small territory of the CTO area, maybe I should not touch.
Open. Okay, thank you. Okay, maybe we can take last questions from Dr. Harris. Any new data from Japan or your center analyzes on CTO outcome?
Okay, very nice question also. So actually, currently in this 5 years, we have a lot of the data of the physiological study, a lot of the data, but no one shows the real meaning of the CTO with checking physiology. Okay, as you already know, Japanese want to do the CTO PCI very much, but never write a paper. This is Japanese actually. This is a little bit shame of us, but anyway, currently from my center, we are doing some study like this. Very interestingly, even a big CTO, after opening up stent, checking physiology show still ischemia. Some case very, improve, but some case not improve. I guess around the 30% case not improve. And also we follow up, and then 1 year later, another half of the case getting better. So now we need to, analyze which CTO is meaningful CTO PCI. This is currently our study. And also, we have also some study. We divided the 3 groups of the open up the LED CTO, open up the RC CTO, open up the circular CTO, and then draw Kaplan-Meier curve of the survivor, patient survivor. Open up the LED, very good for the patient life. Open up RC, I think 50%. But open up the circumference, even a big circumference, patient survival curve, same. This too is our study. And then a little bit shame of us, we have some technical paper from the Japanese, but no, that's kind of outcome the paper.
Okay, thank you, Dr. Sunao Nakamura, for your good presentation. If everything okay, I want to close the program now. Again,
Okay,
I want to thank you for your slides, for your attendance, and I want to thank all of you for your attendance too. And do you want to say something, Dr. Sercan Okutucu, for last words?
Well, thank you very much to you and the professor that given time to us, and we enjoy and learned a lot. And if it is possible, if the attendees open the cameras, and let's wave our hand and close the session. Huh?
Bye-bye.
Okay. So have a nice day. Thank you very much.
Thank you. Thank you.
Bye.
Have a nice day. Thank you.